Welcome back. My name is Michelle Weckman, and I'm a physician at the University of Iowa with expertise in family medicine, psychiatry, and hospice and palliative medicine. In this part of the training program, we're going to talk about delirium as a cause of agitation. Delirium is a common medical condition which is distressing to patients, caregivers, and healthcare providers. Patients with delirium exhibit a fluctuating confusion that is often reversible. In patients with dementia, delirium often results in either extreme somnolence, which can interfere with the patient's ability to interact, or in agitated behaviors, which can be dangerous to both the patient and others. The purpose of this case-based mini-lecture is to discuss how delirium can cause agitation in patients with dementia and to help you to understand the assessment and management of delirium. I will provide a brief overview of delirium, which will cover recognition, diagnosis, evaluation, and treatment. Once we all have a basic understanding of delirium, I will discuss how the pocket guides can be used to assist with both delirium recognition and treatment. As in the other mini lectures, I will use a clinical case to assist in both the understanding of delirium and to demonstrate the use of the pocket guides. As you may know, delirium is epidemic in the elderly. Delirium is especially common in patients with cognitive impairment and can be seen in all settings, including the community, assisted living facilities, nursing homes, and hospitals. As a patient's cognitive impairment or medical condition worsens, delirium becomes more prevalent. However, there are a number of overlapping symptoms between delirium and dementia, and sometimes it can be quite challenging to tease out the two. If your patient has an acute change in condition, activity level, or behaviors, it is important to consider delirium as one of the possible causes. I hope that I have convinced you that delirium is common, but why should you care about recognizing and treating it? Delirium results in significant mortality and morbidity for our patients, and it complicates care. Elderly patients who develop delirium while hospitalized have longer lengths of stay, increased costs, and are significantly less likely to return to independent living. Additionally, patients who develop delirium are commonly discharged back to home still confused. This increases caregiver burden, leading to increased caregiver burnout and a higher rate of nursing home placement. Patients are not the only ones impacted by delirium. Both family and healthcare providers express decreased satisfaction caring for a patient with delirium. They say that seeing and caring for someone with delirium causes them significant distress. Witnessing a loved one suffer from delirium also increases the risk of developing depression and anxiety in bereaved caregivers. We have previously been introduced to Mrs. Klein. She is currently residing at a nursing home with moderate dementia. The Delirium Assessment and Management Card has a basic definition of delirium. Briefly, delirium is the acute onset of brain dysfunction which waxes and wanes. In patients with dementia, we often see increasing confusion, decreased attention, changes in the sleep-wake cycle, as well as new behavioral symptoms. Mrs. Klein exhibited several changes which are indicative of delirium. These include an acute onset, inattention, called the minimum data set required by CMS. The screening that we recommend can be seen on the Delirium Assessment and Management Card. This screen is designed to cover the 4 cardinal features of delirium, which are an acute onset, inattention, disorganized thinking, and an altered level of consciousness. A patient likely has delirium if there is an acute onset and inattention combined with either disorganized thinking or an altered level of consciousness. Acute onset is exactly like it says. Was the change sudden and unexpected, or was it a gradual, slow change? A gradual change would be more representative of progressive dementia, while a sudden change often indicates a developing delirium. In Mrs. Klein's case, the change was sudden after 1 month of being in the nursing home. The other required feature of delirium is inattention. Sometimes inattention is obvious during the time you spend with a patient. If you are uncertain, a simple test of inattention is to ask a patient to indicate when they hear a specific letter by squeezing your hand. We recommend asking the patient to identify the letter A in the phrase "save a heart," replacing the E in heart with an A, so that the series of letters that you would read would be S, A, V, E, A, H, A, R, T. When Mrs. Klein was asked to identify the letter A in "save a heart," she was only able to identify the correct letter 7 out of 10 times. Her score is positive for inattention. With inattention and an acute onset, Mrs. Klein only needs to have either an altered level of consciousness or disorganized thinking to screen positive for delirium. Altered level of consciousness is easier to detect than disorganized thinking, and if positive, you don't need to check for disorganized thinking. For example, if Mrs. Klein was dozing off during your interview, or was restless and unable to sit still, she would screen positive for altered level of consciousness. This, combined with her inattention and the acute onset of behavioral changes, results in a positive delirium screen. However, if she is alert and calm while you interact with her, then her level of consciousness would be considered normal. Then you would need to screen for disorganized thinking. Disorganized thinking occurs when a patient is unable to stay on task, follow a conversation, or unpredictably switches from topic to topic. Sometimes it is difficult to determine if disorganized thinking is occurring or if it is the patient's baseline. In those cases, thinking can be evaluated by asking the series of 4 questions listed on the card and asking the patient to perform a simple command. These 4 questions have been validated and can determine disorganized thinking in patients with mild to moderate dementia. When Mrs. Klein was asked to do this, she answered yes to, does 1 pound weigh more than 2 pounds? And did not correctly follow the verbal command. She had a score of 3, indicating disorganized thinking. Now that you have decided that Mrs. Klein likely has delirium, it is important to consider possible causes. Delirium has many potential etiologies, most of which are easy to identify with a detailed history, physical exam, review of vital signs, and a close evaluation of medications. The medication card is a great resource which can help to identify medications which can cause delirium. If the medication review and the physical exam do not reveal a readily apparent cause, a few basic laboratory tests can be beneficial. Common tests include a urinalysis to check for infection or dehydration, basic electrolytes to look for dehydration or organ failure, glucose to look for hypoglycemia, and a CBC to look for infection. The history and medication review revealed that Mrs. Klein did not consistently take her medications at home and that her oxybutynin ER was recently increased. Mrs. Klein has been receiving her medications routinely at the nursing home, yet was still experiencing incontinence. Physical assessment indicated that Mrs. Klein's vital signs were notable for orthostatic hypotension. She was otherwise afebrile, and her physical exam was notable only for restlessness and poor attention. A laboratory evaluation included a CBC, electrolytes, and urinalysis. The CBC was unremarkable, the electrolytes indicated dehydration, and the urinalysis showed evidence of a urinary tract infection and dehydration. Based on these findings, you determined that her delirium was likely multifactorial, caused by infection, dehydration, and medical toxicity. With attention to finding and treating the underlying cause and starting non-drug management, the majority of delirium cases can be reversed. This often results in the resolution of the troubling behaviors. Effective treatment of delirium is a multi-step process. Most of the steps should be done simultaneously. It is important to clarify goals of care with the family and the patient if able. As soon as you decide a patient has delirium, environmental measures and non-drug treatment should be initiated. Non-drug interventions can be started even in patients whose family does not desire further interventions. In some cases, even simple changes made to the environment, for example, having a beverage of choice available within easy reach and promoting continuous sleep at night, can result in significant improvement in delirium and the behaviors associated with delirium. In Mrs. Klein's case, you decide to implement a toileting regimen, you stop the oxybutynin, which will decrease her exposure to anticholinergic agents. You ask her family and all the nursing home staff to ensure that she has lemonade, her favorite beverage, somewhere where she can reach it. And you request that they offer her a drink at least once an hour when she is awake. You also treat her urinary tract infection with antibiotics. These measures result in the resolution of her symptoms in 48 hours, and her distressing behaviors largely stop. However, there are some situations when a patient develops severe agitation which does not respond to non-drug interventions and treatment of the underlying cause of delirium. If Mrs. Klein becomes so agitated that she is pacing the hall and kicking other residents or hitting anyone who approaches her, it may be necessary to start an antipsychotic for short-term management of symptoms. Haloperidol is recommended for most patients if an antipsychotic is required. Haloperidol should be dosed like you dose a PRN pain medication. A reasonable starting dose is 0.5 milligrams every hour as needed, with the goal of decreasing the distress and agitation. The goal should not be to induce sedation, but sometimes sedation does result. Schedule once or twice daily doses based on the amount of medication needed in 24 hours to effectively control the agitation or other distressing symptoms. Remember to discontinue the antipsychotic once the delirium has resolved. There may be a situation when you do not want to use haloperidol, such as for a patient with Parkinson's disease, Lewy body dementia, or another condition with a high risk of extrapyramidal side effects. For these patients, quetiapine can be substituted, but the risk of sedation is higher. In summary, delirium is very common in patients with cognitive impairment. It is commonly missed because the symptoms can be similar to the behaviors that patients with dementia exhibit. It is possible to identify delirium more often if you have a high index of suspicion and routinely screen all patients who have had a sudden behavioral condition change. Unfortunately, delirium is often missed, leading to significant morbidity and mortality for patients and caregivers. Delirium is a treatable condition, and treatment can improve outcomes. Treatment consists of identifying and treating the underlying cause and starting non-drug and environmental management strategies. Antipsychotics, specifically haloperidol, can be helpful to manage agitation and other distressing symptoms, but should be discontinued when the delirium resolves. While the majority of families and patients will want delirium addressed and treated, some families may not. For example, a family may feel a patient has been suffering and may not want anything done which might prolong life and by default prolong suffering. In this case, a family may choose not to treat an infection which is causing the delirium, such as pneumonia or a urinary tract infection. If this occurs, it is prudent to consider enrollment in hospice, since mortality is significantly increased when an elderly patient develops delirium, and the underlying cause is either not found or not treated. Additionally, hospice has been shown to improve symptom control in nursing home patients and to improve family satisfaction with both the death experience and the perception of care the patient received. Thank you for taking the time to view this mini lecture on delirium as a cause of agitation. We hope that it was informative and will be beneficial. Please take some time to view our other mini lectures designed to guide evidence-based use of antipsychotics in patients with dementia. Have a great day.